Hello, everyone. I'm Andrew Pucker. I'm the Senior Director of Clinical Medical Sciences at Lexitas Pharma Services. And today I'm here with Dr. Ken Sall. He's one of the experts in the field of ophthalmology. I would just like to have him introduce himself.
Hi, everybody. My name is Ken Sall. I'm a retired ophthalmologist. I'm now working with Lexitas. I did 20 plus years of clinical trials, so that's actually what I concentrated in. I would call my practice a research practice that also did ophthalmology. So I'm nice to be talking with you today, and I hope to be giving you some important information.
So thanks for coming today. For everyone, we're going to be discussing actually one of Dr. Sall's papers, which is titled Validation of a Modified National Eye Institute Grading Scale for Corneal Fluorescein Staining. It was recently published in Clinical Ophthalmology in 2023, so it just came out. You can find that online right now if you Google that. But really, Ken, could you just give us an overview about the background on the NEI grading scale and why we should care about this?
Yeah, okay, so we're all familiar with the uses of the dye, fluorescein, lissamine, in staining the ocular surface to try to give us information about the ocular surface. So we're able to assess the integrity of the surface, epithelial defects, punctate keratitis, and then also these dyes are used for pattern recognition, like the dendritic keratitis, as you can say, that's definitely herpetic. But the main thing is we can use them to assess the rate and the process of healing. And healing is the key endpoint of all of the dry eye studies. So that's the major use for the scales. So again, you're used to the scales. The most common one is the NEI. We also have the Oxford. We also have the OSS scale. Now, I'm going to concentrate mostly on the NEI scale, and I'm going to give you some setup and background over the 15 years or so that I've been doing this. So the original NEI scale came out, and it was based on density. So how closely packed the dots are together. So it was a 4-point scale, 0 to 3, and you would then look at your scale reference and look at the cornea and say, okay, that fits into a grade whatever, 2. And then you would record that. That worked, but there were some deficiencies. So it moved on to the NEI dot count. The dot count used the same 4-point scale, 0 to 3, but you would now count dots rather than density. And let's go into a little bit of the history of that. With all studies, the PIs had to be trained. In other words, you can't just say, okay, grade, and not knowing that they're grading the way you expect. So when I would teach the grading scales with the NEI, at the post-meeting reviews or the breaks, I get all these questions, it's really, the density is so subjective. And that's what brought us into using the dot counting system. There were several different dot counting systems, but the ones that most landed on was a 0, obviously 0 dots, a 1, 1 to 15 dots, a 2, 16 to 30, and a 3, 30, a greater than 30 dots, okay? So it moved that way because the PIs loved it. So at the meetings, I think we approached either before or at the end, are we going to be using the dot counting system? Because that definitely works better. And yes or no would be the answer. And the reason it would be no is the scale on dot counting wasn't validated anywhere. So sponsors were afraid, well, if I use this scale and then somebody says, well, this isn't validated, how do we know it's measuring what we want it to? But slowly that moved along to go where the dot counting was accepted. And now it's pretty much used in many of the trials. And finally, what happened was the modified NEI scales. So Lexitas has its own scale, and there were other scales before. Now, the modified scale is a 9-point step. So it's a 0 to 4 with half-point steps, giving you 9 categories. This happened, in my opinion, because there were so many drugs that were not approved. We kept failing, couldn't show efficacy in the staining. So the theory was, well, our grades are too large. We're not seeing a small change. So this is where we went after the 9-point scale to see if we can capture smaller changes to show primary improvement efficacy. All right, so that's the history. The challenge is not grading the cornea. Ophthalmologists, optometrists know how to grade the cornea with corneal fluorescein staining. The challenge is grading similarly by each PI at each visit and at different sites when you have multiple sites in a study. So that's what caused this evolution. All right.
So that kind of highlights the, where we're going with this study, right? So you have these 3 grading scales, and you could hope they work, but we don't really know, right? So kind of tell us how in your study you evaluated if these scales are repeatable or how they compare.
Okay, let me start with, we had a discussion at the beginning, how to design this, everybody does. And first thing we realized, it's very difficult to get photographs of the cornea to be able to use as a reference point for grading. The examiners, the cornea has a curvature. So it's you can't get all 5 zones in the same image in focus. So we ended up using illustrations and photographs, and then overlay the NEI grid that divides the cornea into 5 zones: the central, superior, temporal, nasal, and inferior. Then what we did is had the graders grade the set of pictures, and all the graders had the same monitors, same computers, same software, so that we cut out that variability on different screen views of the images. Well, first we had them grade, each of them would grade all the photos, images, with all 3 scales, okay? And that gave us the inter-examiner repeatability. And then approximately 2 weeks later, they came back and they graded again to see if their ability to grade the same each time, the intra-examiner repeatability. And that's how we set that up. And then, of course, you analyze the data. See, is this going to show that our Lexitas grading scale can be validated and shown to be effective in the grading system?
So you talked about graders, and there's lots of different people out there. Like, who is grading these images? Technicians, doctors, experts? Like, how did that work?
Well, again, that was a good question. We debated that for a while, and we went with well-known experts for grading. We were concerned that the learning scale of a new grader or an intermediate grader could throw variables in that were not reliable or confounded the data. So we went with experts in the grading field to be able to do our reviews.
I think that makes a lot of sense. When you're starting out with something new, you want to go with the experts to see if it actually works. So what did these experts find with these scales?
Okay. They showed that it was equal to or better than the other scales, the Lexitas scales. So that's what it basically showed. We validated that they could do the reproducibly and they performed similarly or better than the other scales. So that was very reassuring that we could validate and show. And again, the other point behind this, it's a 9-point scale, which it was easy for me to read to you the NEI and the NEI dot, because it only had 4 categories. You can remember those in your head. One of the issues with the 9-point scale is you must use an associated form that gives you what your categories are. So you can't count dots in your head looking at the surface of the eye and then make that transition to what grade it's supposed to be. So again, we were pleased that they were able to come up with a reproducible grading system.
I think that's a couple of good points. So I think good practice with any grading scales to have it right in front of you when you're doing it. So the graders incorporated that. And then one thing that I think is interesting and maybe even unexpected is that the 9-point scale of the Lexitas modified grading scale actually was just as repeatable as the 0 to 3 scale with the original NEI scale, which I don't think really would be expected since, you know, you have bigger bin or smaller bins in the 9, right, compared to the 3. So I think that's actually really cool. And it also suggests that the directions are clear, right?
Yes, that's one of the things I'm going to mention here also is, you know, as Dr. Pucker has mentioned, this article has just been released and this hasn't even been discussed yet. But how do we use this in clinical trials? I think we've explained, but I think this can be used in the office practice also, because we now train our PIs due to the COVID, you know, nobody gets together. We train the PIs on a web-based system. And they are trained, and then they have to complete an assessment. They have to pass the assessment. And the vast majority, whether they're first time getting into research, you know, been in research for a while and grading, pass the assessment at the first try. So it's you know, easily used and easily explained and reproducibly trained. And I'm pleased. And the point I was making is, I'm hoping that Lexitas moves into making our training web assessment something that you can log into to train yourself to be able to use this in your practice. We haven't really discussed that yet, but I'm hoping that's where we go.
And I can't tell you the details, but we are moving that way. So we're thinking the same way at Lexitas.
Another thing, hot off the press.
Yeah. Okay, so just one last thing I want to ask before I get your conclusions. So we have these expert graders, they gave us some information, we have this cool paper. How do we implement this in practice? Like, how do you envision your typical investigator on a study learning this and using this beyond, you know, the portal that we just kind of talked about?
Yeah, like we said, so in the clinical trial, they will go through some sort of training practice. But what I expect them to do is say, hey, this really works. And I can use this in my regular practice also now that I have a reliable grading scale that is reproducible. And the other points I want to mention, I mentioned this earlier, there are some other 9-point scales. And, you know, we approached the KISS principle, you know, just we took out some other factors that could be confusing. Some of the other 9-point scales refer to macropunctate, clumping, those, you know, well, how big is a clump? How big is it before it's a macro? So our scale just basically works on the dot counting system and the area of involvement in a zone, and then how, you know, do they start to group or do they start to merge? And once you look at the article or it's a sheet that shows all the categories, that will be much more clear. It's hard to describe that verbally. But your answer, it's going to be used in both places, office.
Perfect. Well, do you have any concluding marks for our viewers today?
No, I mentioned that there's all the different scales, and I think everybody's got the understanding that these scales keep progressing because we try to make it better. And I think we have reached that point. I hope you'll look at the article in print, and I'm looking forward to having a web-based testing so you can feel comfortable with the system yourself. And that's it. Thank you.
Perfect. Well, thank you, Dr. Sall, for coming to talk with us today. I'd like to thank you all for tuning in. And I do need to make you aware that this article is open access. It's free for you to download, and we'll try to post that along with this video. So thank you for your time, and I hope you have a great day.
Thanks, everybody. Nice to talk with you. Bye-bye.